Thank you very much for allowing me to come and talk to you today about wrist fracture and particularly K-wiring of wrist fractures. My name's Matthew Ricks. I'm a consultant hand, wrist and upper limb surgeon over at Wrightington Hospital in the UK. I've got learning objectives that we'll cover, which include understanding the limitations of K-wiring of a wrist fracture, demonstrate certain reduction techniques to aid fixation, appropriate assessment of reduction and fixation, and to understand the post-operative management for a K-wiring. I'd like to first say that I've had the pleasure of visiting Blantyre, Malawi for a travelling fellowship and spent some time out there. And so I'm very fond of the area and the people and how much of a beautiful country it is. So thank you so much for allowing me to be part of this. And I hope to come back soon to see you all. So what are we covering? We're covering MUA and K-wiring with distal radius and take you through a case mix and talk you through certain elements of the fixation that we did. So the clinical scenario we use is a 56-year-old right-hand dominant engineer who fell onto an outstretched hand, sustaining this injury here. You can see it's an extra-articular distal radius fracture of both the AP and lateral projection. You can see that we've lost a significant amount of radial height on that AP, and there's a tilt radially. And on the lateral projection, you can see that there's a dorsal tilt of about 20 degrees and a degree of translation dorsally to that distal fracture element as well. So I would manage this with a manipulation in theatre and K-wiring. I position these patients supine with an arm board and a tourniquet, essentially positioned within the laminar flow with a single leg arm board. This single leg arm board allows me to get C-arm in and out easily, which is key during the operation. I sit in the axilla, the fellow or assistant sits the other side of the table, and the scrub nurse tends to sit at the end of the arm board. Marking up of the skin is a key part that I do. I try and decrease the number of K-wire passings to the bone, just to try and A, decrease your insult to the bone, but B, the more passing you do of the wire, the more channels you're creating, the more chance there is of you going down those same wires. I also like to think that the markings of the skin allow me to get a three-dimensional understanding of the fracture and the bone underneath. So I mark a number of elements of the fracture. I mark the long axis, the radius, which you can see, the radial styloid wire axis that we're going to do, and a longitudinal wire of the radius as well. And this is on the lateral aspect to allow me to get a configuration in my head of the line that we're going to put the wire in. I also mark up the fracture site and the insertion point of the wire, particularly the dorsal aspect as well. This is done under X-ray guidance, and to try and minimize the number of X-rays, we get one in AP for each of the wire positions, then one in the lateral position as well. Things to consider when K-wiring, the limitations of K-wiring. If you've got an intra-articular comminution, a lunate die punch, or poor bone quality, you need to consider whether you're doing the right thing with K-wiring. Sometimes there are limitations to K-wiring, particularly intra-articular fractures. You may struggle to reduce or even hold these fractures with a K-wire. And another factor I want to point out here is the associated injuries with distal radius fractures. Look for the associated fractures. Look for any scapholunate ligament injury that you may have with these patterns, because they are there and they have associated injuries with them. So just make sure you're always keeping an eye out for that. We know that there's certain angles and heights of the distal radius that we're trying to restore. The radial inclination, the radial height is key, as well as your neutral to volar tilt that you have on the lateral. We're trying to restore an anatomy that will give your patient the function that they can return to the activities they want to do. A Kapanji technique is a technique we all use to help reduce these fractures. It's a fantastic way of passing a wire into the fracture site and levering and hinging that fracture back into the position. You don't have to do this just dorsally, you can do it radially as well, depending upon the fracture pattern you have. Now, a tip that I do is I use X-ray to mark up the fracture site. To do a small skin incision, I use a clip down to the bone. I place my wire on the proximal aspect of the non-broken bone. I then sweep it up along the long axis of the bone, allowing me to pass that wire into the fracture site. I then pass that wire into the volar through the dorsal into the volar cortex and use that to lever. You can see from this bottom right X-ray that we're using the wire to help lever that dorsally angulated fracture back into a neutral to volar tilt. And this is a powerful way of reducing your fracture back into position. I tend to hold it with a K-wire, check I've reduced it, and then use another wire to hold it back into position. Sometimes if I'm worried about the fixation, I will drive that Kapanji wire through, then leave it in, but most of the time I will do supplementary wiring of the radial styloid and of the dorsal wire as well. Here's an X-ray showing us with a Capandry wire still left in, and then we end up removing it before the end of the operation. So I use skin marker pen and the references in the skin to help me aid my wire position, to try and decrease the amount of exposure from the X-ray, but also to try and minimize the passing we're doing. I do tend to do a single pass, ideally, of a bicortical wire. And if I'm concerned, similar to distal radius fixations with plates, if I'm ever concerned about my fixation technique, I would either reposition a wire or add another wire to it. I have no issue with adding multiple wires to stabilize these complex fractures if need be. But if I find I'm struggling to fix it with K-wires or hold it with K-wires, then it may be that you've chosen the wrong option for it and you should consider a plating. So once I've done my fixation, I'm happy that I've reduced it into a good position. I've got a sound fixation, it's reduced and stable. Then I assess stability on table. I look at the wrist through a range of movement, I screen it. And so that allows me to see whether I've stabilized it. What I'm looking for particularly is whether there's any dorsal tilt or dorsal translation of that fracture. And if I have any concern about stability, I will end up aiding my fixation with a further wire, and in rare occasions I convert it to a volar plating. But most of the time, if you do a sound fixation, you can get a good reduction technique with your K-wire. Thank you very much.